Welcome to this webinar on the clinical impact of next-generation sequencing, NGS, in reproductive medicine. First, for a brief introduction into genetics, and just as a reminder, in each cell of our body, we have 23 pairs of chromosome, and one can imagine that each chromosome is like a volume or a book in an entire encyclopedia. And just like the book has many different pages, so does the chromosome has several different genes. And totally, we have about 20,000 genes. A gene is actually a recipe that encodes a certain product, usually a protein, that is responsible for our normal development and health. The entire genome is composed of 3 billion base pairs. But the coding region, the part of the genome which encodes for proteins, is only about 1 to 2%, and it's called exome. We'll discuss this towards the end. So during our webinar, we'll talk a little bit about the NGS technology itself, some of the most useful applications like whole genome and whole exome sequencing. We'll talk about non-invasive prenatal screening, about carrier screening, and finally about pre-implantation genetic screening. So first, let's talk about the NGS technology itself. What is NGS? Well, first we need to know what is the first generation sequencing, which is called Sanger sequencing. And in the picture here, you can see rows and rows of such sequencers that were used to generate the draft of the first human genome. These machines can analyze only about 1,000 base pairs at a time. So it requires a huge number of these machines to generate the entire human genome. So just to sample one genome took about 15 months and cost more than $1 billion. Next generation sequencing, on the other hand, allows you to perform whole genomes within a few days and at a cost of about $1,000. And with the time, the machines get better and better. So new machines can sequence 50 genomes at a time. It takes only about a couple of days. So the technology behind these machines is based on the fact that one can take a DNA sample and put it on one of these flow cells that you can see down here at the bottom. And the flow cell has many different probes that allow you to place your DNA within this flow cell. And then what happens next is the DNA samples bind to the probes on the flow cell, and you can have millions and millions of such DNA fragments attached. Following these attachments of these probes, the machine allows you to sequence each fragment individually so that with each different letter of the genetic code, you get the sequence, and this is done simultaneously, capturing tens and even hundreds of millions of these DNA fragments and allowing simultaneously to sequence all of them. And after each sequence is defined, then the sequence is aligned to a reference genome, and this allows you to determine the sequence of the sample that you have tested. When this is done, you can get different coverage. That means the NGS test may test several different parts of the genome or the entire genome, and we'll just discuss this later. And depending on the number of sequences that are tested, you can have growing depth, which allows you to define small mutations that occur at a very small range. When one does next generation sequencing on a sample, and if it's an exome sample, the result is tens of thousands of variants. Not all variants are pathogenic, but one has to first detect them. And when one performs whole genome sequencing, the number of different variants may reach several million, about 4 million at a time. So it's not enough to detect the variants, the changes that are within the sequence. Then you need to try and filter them to see which of these variants seems to be most suitable for the diagnosis that is made. And this is based on different softwares that allow you to place some of your hypotheses depending on what the disease that is tested for, what is the suggested mode of inheritance, and so on. And even after that is done, you're still left with quite a large number of variants. And next thing you have to do is to classify them, because some of the variants may be in the gene of interest, but they may be benign. They may not be pathogenic. So it takes some time to perform the bioinformatics pipeline that is required for proper understanding of this technology. So let's talk a little bit about the possible applications for which next generation sequencing is used. This can now be clinically applied because once next generation sequencing has entered the scene, the cost per genome has decreased significantly, is continually decreasing. So that allows one to utilize these once expensive technology in the clinical settings. So the first kind of test that is performed are targeted gene panels. This is sequencing just known specific genes that are associated with a clinical phenotype. Then you can use the clinical exome just targeting known regions, or you can sequence the entire exome or go to whole genome sequencing. So let's start with targeted gene panels. This is an example that I used. I used a resource called a GTR, Genetic Testing Registry. And in this website, one can look for different laboratories that perform different tests. And here I placed Noonan syndrome in the search bar. And this showed me several possible laboratories that perform panels for Noonan syndrome, because Noonan syndrome may be caused by several different genes. These type of tests are used more and more commonly when a known clinical phenotype is presented, but it may be caused by different genes, rather than going piecemeal and checking one gene at a time. The next commonly used example of next generation sequencing in this arena is the exome sequencing. The entire exome, as I said before, is about 1 to 2% of the entire genome. And one exon of a gene is usually quite short, 145 base pairs, and an average gene contains about 8.8 exons. So one can imagine that 20,000 genes have many different exons. The exome itself, as I said, is about 1 to 2% of the entire genome, about 15 million base pairs. However, it contains about 85% of disease-causing mutations, so it's a good target to start looking for disease of an unknown origin. And there are about 7,000 different Mendelian disorders that are known. So when one doesn't have a clear idea of what the condition is, then going for whole exome sequencing is a good idea. To perform that, one needs to take the DNA sample and then use specific technologies to capture just the exons of the genes that are tested for. This used to be an important issue because the sequencing part was quite expensive, so one had to devise ways of performing tests of clinical relevance at a relatively lower cost. This is slowly disappearing because the cost of sequencing is continually increasing, so that perhaps this step will be used less in the future. But performing the sequencing, as I said, is not enough, because once you start performing whole exome sequencing, you get about 60,000 variants. You need to start filtering them according to different criteria, such as allele frequency, taking out all variants that are common or known to be benign. You are left with several hundreds or more, even 10,000 genes, and you start having to filter them by the phenotype or by the inheritance pattern that you believe is causative, and then you wind up with a shorter list of variants, and you have to manually curate them according to literature and using different software. So it takes quite a long time, 10 to 17 hours even of expert time. So currently the cost of interpretation is even the cost of sequencing itself. Whole exome sequencing, WES, has been used quite extensively in postnatal studies. And here is a list of publication beginning at 2013 with hundreds of patients in most of these studies. And they were performed on individuals with different neurodevelopmental problems usually, but the resolution of the cases is only 27%. And this is not surprising because we know that some of the conditions may not have been inherited, and even using whole exome sequencing, we cannot detect most of the cases. Still, it allows you to detect previously undefined conditions and symptoms. Then in the last few years, whole exome sequencing has been used more extensively in the prenatal settings, usually on fetuses with ultrasound abnormalities or and so on. And the detection rate is varied with different studies depending on the population tested. In some of the cases, the detection rate was quite low, and in some of the cases, it was quite high. Then recently, just last month, the British Prenatal Assessment of Genome and Exome, called the PAGE Consortium, has just reported in the Lancet about 610 fetuses with structural anomalies and with matching parental control, so that's about 1,200 samples more. And interestingly, they found 321 variants that were potentially pathogenic. However, when they start doing the required bioinformatics, they realized that a clearly diagnostic variant, a pathogenic variant, was identified in 8.5% of the cases. Mind you, this was after exclusion of aneuploidy and copy. This is a true increment in the diagnostic ability. And in an additional 3.9%, they found a variant of potential importance that required further workup. However, in cases where there were multi-system anomalies, more than 2 anomalies, the added detection rate was 15.4%. So this is quite an important contribution in the detection of fetuses with ultrasound abnormalities that were not resolved by standard testing. And the lowest yield was in fetuses with isolated nuchal translucency, only 3.2%, but that too is of importance. However, prenatal whole exome sequencing cannot resolve everything. The problem is with an incomplete fetal phenotype. Unlike the born child or the adult, some of the fetuses that are afflicted with some genetic syndromes don't manifest them at all, or may manifest some of them. Turnaround is an important issue because of the time required for making clinical decision. The variant interpretation may not be easy enough and requires personnel that are well trained. It's still quite costly. There's some ethical and social factors and factors having to do with detection of variants that are not associated with the condition or with a pathogenic, with a clearly significant reason for the malformation, such as variants that cause late onset diseases and so on. And also, whole exome sequencing cannot detect aneuploidy like trisomies or copy number variants. It cannot detect structural rearrangements and mosaicism and so on. So it's still not a panacea, not a clear solution for all problems. Whole genome sequencing allows you to sequence not only the exons, but the introns themselves and the intergenic regions. And due to improvements in technology and bioinformatics and the decrease in cost, we will see in the near future increase in the utilization of whole genome sequencing, also for in the prenatal settings. And there are also already some companies that offer these testing for prenatal samples. The workflow is simpler. You don't have to perform exome capturing. The coverage is better. There's less variability, and it provides a wider range of detection because it can detect non-coding variants, so variants that cause a disease but are not within the sequence itself, and it can also detect copy number variants, rearrangements, and even aneuploidy. But that will increase the challenges because once you identify variants of unclear significance and incidental findings, these will increase more regions of the genome. So this is just an example of the higher detection rate that is provided for by the increasing technologies, beginning with Sanger sequencing. It only detects few cases, and up to whole genome sequencing that probably will increase our detection rate in the prenatal setting. Next, we move to another application of next generation sequencing, which is the non-invasive prenatal screening, or NIPT as it's also called. This is based on the fact that during pregnancy, DNA from the mother, from the fetus, and more precisely from the placenta, enters maternal circulation. And these are called cell-free DNA fragments because they're not within the cell nucleus. They're short, about 160 base pairs in long, and released into the maternal plasma. And from about 10 weeks of pregnancy, about 10% of the cell-free DNA in maternal serum is of fetal origin, and it disappears shortly after birth. So this can be used to detect some fetal abnormalities, particularly aneuploidy. And what is this test based on? Just let's assume that we would like to detect trisomy 21, which means that the fetus has an excess of chromosome 21. That would mean that the fetus will release into maternal circulation more fragments from chromosome 21 than from any other fragments. So let's just assume that this here is a euploid sample. The fetus is euploid, and since the fetal cell-free DNA is only about 10% of the total cell-free DNA, then from each from the maternal circulation, in this case, 90 fragments of DNA from chromosome 21 compared to 10 from the fetus. This is because 10% would be a fetal origin. If the fetus is affected with Down syndrome, then the amount of maternal DNA would be the same, but there would be an increase in the cell-free DNA from the fetus. And this is about a 5% increase in this case. And it's quite difficult to detect changes that are only 5%, but thanks to next generation sequencing, one can sequence many different fragments of cell-free DNA at a time, and this allows you to detect even minute changes. Once the sequences are detected, then we count how many fragments come from each chromosome, ending up with this type of histogram, and depending on the difference between the observed number of counts versus the expected, the difference, once it's greater than 3 standard deviation, means that the fetus may have this aneuploidy, such as trisomy 21. Currently, non-invasive prenatal testing usually tests for the common aneuploidies, such as trisomy 21, 18, 13, the sex chromosome anomalies, and these account for about 83% of chromosomal aberrations that are detected in standard amniocentesis. These tests are highly sensitive. For trisomy 21, the sensitivity is greater than 99.7%, and also for the other chromosomal abnormalities. The false positive rates, on the other hand, are extremely low. And if you accumulate all the false positive rates from different tests, the false positive rate is much less than 1%. And this is compared to standard biochemical gene, for which the false positive rate is about 5%. So these tests are highly sensitive and specific, and the positive predictive value of these tests is high. The positive predictive value means that once an abnormal result is given, what is the likelihood that the fetus is truly affected with this condition? So depending on the prior risk, say a patient with high nuchal translucency was about 40 years old, the prior risk for Down syndrome is 1 in 10. Given an abnormal result, the positive predictive value is greater than 99%. But even in the low risk population, the positive predictive value of NIPT is quite high. And again, compared to standard screening tests, for which the positive predictive value is only 2 to 4%. So no wonder these tests are becoming more and more popular, and several countries in Europe into clinical practice. Next topic is carrier screening. So the objectives of carrier screening is to identify at-risk couples and provide them with genetic counseling and offer reproductive options such as pre-implantation genetic diagnosis if they're not pregnant yet, or if they're already pregnant, offer them CVS or amniocentesis. What should we screen for? As I said before, there are 7,000 human conditions that are caused by single gene disorders, and we can't obviously screen for all of them, but we would like to screen for conditions that cause cognitive disability or require surgical or medical interventions, such conditions that have a significant effect on the quality of life, and conditions for which prenatal diagnosis may improve outcome by early intervention or delivery in places where optimized newborn care is possible. Most of the conditions that we screen for are autosomal recessive inheritance, meaning that the parents are both normal, but they carry one abnormal gene. However, they have a chance of 1 in 4 of having a child affected with the condition. Standard screening is usually performed in a stepwise manner. So one partner is usually screened, usually the woman, and in the entire population we look for carriers of the specific condition. And then we take only the partners of the carriers and we screen them. And if we find that one of the partner is a carrier, such a carrier couple is offered prenatal diagnosis or pre-implantation genetic diagnosis. And here are some examples of pan-ethnic genetic diseases. Fragile X syndrome is obviously not an autosomal recessive, but it is quite pan-ethnic, less common in Southeast Asia. Cystic fibrosis is quite common, spinal muscular atrophy. So if you want to screen only for a limited number of conditions, here is a good big place to start. But in certain population, the number of tests that are screened for, it gradually increases. For instance, in the Ashkenazi Jewish population, we started screening with Tay-Sachs, but the list of conditions significantly increased as time went by. So it is becoming quite difficult to manage. Also, populations move from place to place, and some individuals don't even know their ethnic background. So there is a paradigm shift moving from ethnic-based screening for particular patients to what is now called expanded screening paradigm. In this paradigm, all individuals, regardless of their ethnicity, are offered screening for the same set of conditions, and using modern technology, one can screen at the same time for hundreds of different conditions. In the past, we used to counsel patients on these conditions, but now it's becoming not possible. You have to counsel, but you have to counsel kind of a general way. Here are some example of providers that offer such expanded screening tests. Each one of these have greater than 100, some have close to 500 different conditions that are screened for, and this provides you with the ability to detect carrier parents in families that were not known to be carriers before. And it's expected that about one out of 2 or 3 individuals is a carrier of one condition, but about 1 in 100 to 1 in 200 couples both carry mutation in the same gene. So this is important because now these tests can be offered to patients. It's becoming more and more widespread. Again, the ability to perform such widespread type of testing for many, many different conditions is thanks to the ability of the next generation sequencing technology. And the last part, I'll be talking about pre-implantation genetic screening, or it is, as it is now called, pre-implantation genetic testing for aneuploidy, PGTA. So during the talk, I will refer alternatively to these two terms. So the rationale behind this was that aneuploidy increases with age. Aneuploidy is a leading cause of miscarriage and congenital anomalies. And we know that more than 50% of human embryos are aneuploidy. So the idea is to offer pre-implantation genetic testing for these aneuploidies to patients at risk, such as those of advanced maternal age, those with recurrent implantation failure, or those with recurrent miscarriage. And in the beginning about 1995 or through 2007, the technology that was prevalent was, for instance, in situ hybridization, and this allows you to tell the difference between a fetus that has a normal chromosome composition compared to one that has a trisomy. This became quite popular, usually testing for a limited set of chromosomes, the 18, 13, 21, and sometimes additional number of chromosomes. However, after a few years, some randomized controlled trials have shown that PGS in its current form does not really improve outcome, and in certain studies it even of pregnancies. This may have been caused by the fact that the embryo has been mosaic. We tested only a limited number of chromosomes. FISH technology was not accurate, and the biopsy itself may have been detrimental. In the late 2000s, a new technology emerged, replacing FISH, which was comparative genomic hybridization. This allows to test for aneuploidies in all chromosomes. Here you can see a panel of a normal embryo, pre-implantation embryo. This is chromosome 1, 2, 3, and so on, up to chromosome 22 and the sex chromosome. So a normal individual will have a line, this probe will be between these two lines. This is normal. And this sample is aneuploidy that has a trisomy here, a monosomy here, and another trisomy here. So this would obviously be an embryo that would not be transferred in IVF. And in the last few years, next generation sequencing is replacing comparative genomic hybridization, because this allows you to detect a wider range of condition. The resolution is greater, and one can pool the samples. So it can detect aneuploidies, but also can detect copy number variants, which are responsible for some of the abnormalities. And because the samples can be pooled, the costs can be decreased. So again, next generation sequencing is being utilized more and more, even in the PGS setting. However, because this test has a higher resolution, the test can also detect cases of mosaicism, which means that the sample has aneuploidy in some of the cells, but not in the others. And this in itself is still an issue for discussion, and there's a lot of debates about the importance of mosaicism in PGS. However, before next generation sequencing, this issue was less discussed because it was not detected. So in summary, next generation technology is now and will continue to revolutionize reproductive medicine. It has a growing number of clinical applications, as I've shown you, and I'm sure there will be more in the future. The patients are now well informed, and some of them already come and ask us to use these tests. So reproductive endocrinologists, maternal fetal medicine specialists, and even primary care obstetricians need to stay updated because this is a very fast evolving field. Finally, I'd like to plug in COGEN, which is a meeting dedicated to these issues, preconception testing, pre-implantation genetic screening and diagnosis, and prenatal genetic diagnosis. The next meeting will take place in November 7 to 9 in Paris, France, and you are welcome to log on to our website to see more details, as well as to watch talks recorded from previous meetings where you can have an idea of what this meeting is like. So I think we'll conclude here, and we have time for some questions. So I'll have the questions transferred to me from the organizers. So let's see if we have some questions. Okay, let me see here. Okay, so here's a question. Can whole sequencing be used to identify all disease-causing mutations in a pre-implantation embryo? Yes, actually, this technology allows you to test and perform whole genome sequencing even on single cells. This means that the entire sequence of an embryo can be detected even before it is implanted. The problem with this is that we all carry hundreds of different mutations. Some of them are really pathogenic and may affect our quality of life or lifespan, but many of these variants or mutations are responsible for late onset conditions. So I can imagine that it will take some time before this thing is utilized, because probably no embryo will be suitable for transfer, because each embryo will have some mutations. And interestingly, I picked on this question because we will have a debate exactly on this topic in the upcoming COGEN meeting. Next question. Will NIPT eventually replace invasive testing like amniocentesis? Well, even if the technology for NIPT improves, it is still, and probably will for a long time, be considered a screening test, because as you recall, the cell-free DNA is released from the placenta, and in some cases the fetus may be mosaic, such that the placenta may be normal, but the fetus may be having a chromosomal aberration like trisomy 21. And in fact, it's calculated that about 1% of Down syndrome cases are the result of such mosaics where the placenta is normal, but the fetus is affected. So cases like these cannot be resolved by non-invasive prenatal screening. Nonetheless, as a screening test, it is far superior than any other screening test available to date. Okay, here's another question. Does everyone need a carrier screening even if they're not Ashkenazi Jews? I've shown this example because the Ashkenazi Jewish panel was previously considered one of the widest panel used for carrier screening. But obviously, each ethnicity has its own set of founder mutations or even private mutations that the parents may carry. If you're using next generation sequencing, then you can detect all different mutations in the same gene. So not like standard tests where a set of different mutations or a set of known mutation is tested. When you perform next generation sequencing, you can sequence the entire gene and detect both common and rare mutations. So this type of test, expanded carrier screening, is designed for different ethnicities. Any more questions? Okay, so I think this is all the time we have for today. Thank you all for attending, and I hope to see you in our next webinar, and also hope you come to COGEN in Paris this November. Thank you and goodbye.